So what do we do given these emerging threats? We're just talking about heroin, we're talking about fentanyl, we're talking about xylazine, and there are others. Thiopentine was one that's out there too, that's really an opioid and was marketed for everything under the sun, and depression and anxiety, but it's a mu receptor agonist. So there's an overdose prevention toolkit from SAMHSA that will help to kind of, somebody is at risk for overdose, you really have to follow this protocol. And the resource kit looks at the scope of the problem, strategies to prevent overdoses, resources, first responder steps, information for prescribers, safety advice for patients and family members, and information on recovering from an overdose. So who is at risk for overdose? Anyone who uses opioids for long-term management of chronic pain is at risk for overdose. Also, people who use heroin or misuse prescription painkillers or patients with addiction. Others at risk are those receiving rotating opioid medications, people who have been discharged from the ER after they had an overdose, people who need opioid pain relievers coupled with a suspected or confirmed substance use problem, history of non-medical use of opioids or illicit opioids, people who have completed detox and are abstinent for a period of time. I'll pause on that one because is detox treatment or is detox stabilization? What are the relapse rates of someone with addictive disease if they do detox only? Yeah, near 100%. Detox, think of it as stabilization. I just prevented a seizure. Did I learn the tools necessary to live life without substances? No. I have to practice that. That's going to take time. The National Institute of Drug Abuse, NIDA, has identified 13 principles of effective addiction treatment. One of the 13 principles that NIDA has identified is it takes a minimum of 90 days of treatment. 90 days to make any kind of headway into this illness. Not 5 days of detox, not a detox unit at home. That's just going to basically prime them. So maybe we have averted a catastrophe and they didn't die this time. But boy, if they don't have the proper placement after detox, they're just at risk, like sort of in a way, maybe more the same or more. And it goes, the other way is released from incarceration. Okay, so why is that? I go into prison, right? Because I have a health condition, so I'm stealing for my drugs. But otherwise, I'm a good person. But I got sick and I'm stealing for my drugs. I get locked up for 5 years. While I'm in prison for 5 years, I don't do any work on my illness. I went in with type 1 diabetes, right? What did we do for type 1 diabetes when I went into jail for 5 years, or prison for 5 years? Nothing. So if I come out, low dopamine in the nucleus accumbens is still there or it's gone? Still there because I never treated the primary illness. Now, if I go abstinent for 5 years, my dopamine does improve a little bit. But the reason I started using compulsively in the very first place is because the dopamine was low. So although I'll get some amount of healing and my dopamine will come a little bit up, there is a threshold in the nucleus accumbens. There is a barometer, if you will. I call it the I'm okay line. It's like filling a gas tank. That line, if I have less dopamine than the I'm okay line in the nucleus accumbens, I'm going to I'm going to seek a way to feel better, and I'm at risk for relapse. But if my dopamine is full in the nucleus accumbens, I'm really not going to seek drugs and alcohol because I'm okay. I'm not 5 days in the seawater, right? So release from incarceration and from detox. Those are going to be. So how do we prevent overdose death? Well, number one, effectively identify and treat those suffering with addictive disease. That would be obviously first. Then we can ensure access for treatment, which, as pointed out appreciatively, is, we have problems with access to treatment. Not just willingness to go, but we just don't have enough folks who specialize in this treatment and enough teams to deal with the crisis. So we hope that will continue to improve and increase because we need it to address the overdose epidemic and to address the disease as an illness in and of itself. Whether COVID pushed up the numbers in the last 2 years of overdose or not, there is a baseline level of prevalence of this disease, which is probably close to 20%, if not 15, if you want to say 10, whatever. It's a lot of people. A lot of people have this disease, and we need treatment for it, whether there's COVID or not COVID. Doesn't matter, we still need to treat addictive illness. And that's a lot of people to take care of. Last I checked, 330 million, 10%. Make room for 33 million people somewhere. Encourage providers, persons at high risk, family members, and others to learn how to prevent and manage overdose. Ensure ready access to naloxone. Again, this is reactionary, right? We're not preventative. We're talking about having naloxone after they overdose, so they're already dead, and we're trying to revive them. Encourage the public to call 911. Encourage prescribers to use the PDMP. We have that law, but how many people are using it? I'm not sure, and I don't want to know. But let's use the PDMP, and that will show us if somebody has a pattern that is suspicious for having the disease of addiction. One of the medications mentioned there is naloxone. Several of you are familiar. It's an antidote for opioid overdose. It's an opioid antagonist that is used to reverse the effects of opioids. Naloxone works by blocking opioid receptor sites, yes, all of them. It is not effective in treating overdoses of benzos, because for that we use flumazenil. Yes, barbiturates, clonidine, which is like xylazine now, GHB and ketamine. What's GHB? Gamma hydroxybutyrate. Think of it like a sedative hypnotic. It's going to be in that family. It's also not effective in treating overdoses of stimulants such as cocaine and amphetamines, methamphetamine, MDMA. However, if opioids are taken in combinations with other things, then naloxone will be helpful. And again, things will be taken in combination. Why? Because it makes sense. Why does it make sense to take things in combination if I have addiction? Because I'm searching for more dopamine. How do I get more dopamine? I need to press the button in another way. I press the button, the opioid button, 1,000 times, and I'm pushing the limits. I need more dopamine. Give me another class of substances. Suspected fentanyl-involved overdoses should be treated with naloxone, but because of the higher potency of fentanyl and fentanyl analogs, compared to even that of heroin, large doses of naloxone will be required. Thank goodness those things are sold in 2-packs, and they'll always be needed in 2-packs, I think, or at least in the near future. The rescue Narcan nasal spray, instruct your patients to get both ready. We need oxygenation to, sort of help in the overdoses now because of the xylazine. They're going to need to be oxygenated and ventilated because they're having so much on board. So, in September of 2022, the state of Florida Department of Health issued a standing order for naloxone. So, no prescription is needed to pick up naloxone rescue medication for patients and family. However, I would recommend writing it. If you're writing opioids, I would recommend to just write it right behind and have a part of the discussion, right behind the opioid, so that you can explain how to or what to do in case of an emergency or in case they show signs or symptoms of oversedation. Delivery systems for naloxone. There's 2 FDA-approved forms. There's an injectable and a prepackaged nasal spray. Injectable may be administered intramuscularly, often into the thigh and through clothing if necessary, if it's a real emergency. And it's for the public. They're not going to really disrobe or cut the clothing off, like we would do in the ER. It's just going to be put the needle in the thigh and administer the medicine. Often to families, though, I recommend, rather than the injectable, is the nasal spray. It comes in a 2-pack, thank goodness, 1 nostril at a time. Individual is typically, supine, and you just have the family spray. If there's a suspicion, you have them administer a spray of the naloxone. Well, each device only has one. Better get it right. I mean, if you miss, there's a backup one there, but it's just if the family's nervous or whatever, there's a 2-pack of that Narcan nasal spray or naloxone nasal. You got to get one of them in. But they still need to call 911. It's not like buddy system where I'll administer the Narcan and we'll be okay. You got to tell them, look, if you have to give this stuff, you got to call 911. You're probably going to need a lot of, whether it's oxygenation or something else. So it's not just one and done. Storage needs to be mentioned. That whether it's the nasal or the injector, you got to have it readily accessible, temperature, and not too much light exposure, and the temperature extremes. There can't be too much on that. It has to be kind of a room temperature and in a dark place. Keep medicine safe, of course, where children or pets cannot reach it. So, kind of the teaching part for the family and the patients is like recognizing the signs. If your loved one is pale or clammy, there's a change in color to the lips or fingernails, particularly blue or purple, person is vomiting, the person can't be awakened from sleep, or their breathing is very slow, and the heartbeat is very slow. They might not like it, as you all know, but you gotta wake them up. And also, part of the education part is after they administer it, the person's going to be probably pretty angry, but they sort of, in the way of saving their life, you got to do it. So this is back to just more signs, or sleepiness, drowsiness, mental confusion, slurred speech, shallow breathing, pinpoint pupils, slow heartbeat, low blood pressure, and difficulty awakening. So give it into any suspected, doesn't have to be confirmed. That's the language that the CDC uses, any suspected overdose to reverse any opioid effects. We mentioned that it won't reverse everything. It's like sedative hypnotics, so it's important to call 911. Keep in mind some good Samaritan laws are in place in most states to protect those who are overdosing and anyone assisting them from legal problems. It won't cause any harm if there's not any opioids involved in an overdose, so encourage them to give it. Rescue breaths, that's been controversial with CPR, hasn't it? Chest compressions only. But remember, this is hypoxia. This is shallow breathing. And if the person's had opioids for an extended period of time or higher doses, they've been under kind of a hypoxic stress, they've been under low oxygen for a while. So one of their main problems, they might even have, if they don't have a pulse, of course you do chest compression. But they might, still have a decent pulse, and their heart might be, sort of doing its job, but they're hypoxic. So that's why the recommendation is talking about rescue breaths, bag, valve mask type thing, making sure that they're in the right position, head tilt, chin lift, pinch the nose, slow breath, watch the chest. So basic CPR, but they give some stress on these overdoses with the perfusion relating to respiration rather than just chest compression. So this is, just some basic things you've probably heard before, except I'll start with, question is decreasing risk in opioid overdose. Again, back to effectively identifying and treating those suffering with addictive disease. I think that's our part today. And what we can do in our microcosm is to identify and treat these people as best we can. There's a lot of other factors, which have been mentioned and brought out, that might be swirling around different things. Well, what's our little part of the microverse? What can we do if we can identify and get these people some help? That would be a good thing. But then there's these following things that are pretty straightforward and kind of obvious, a little bit painful to read. Take medications only as prescribed. Well, that's kind of obvious because Don't mix pain medications with alcohol, sleeping pills, or illicit substances. Learn the signs of overdose. Teach family members how to respond to an overdose and dispose of unused medication properly. Well, there's a point. There's a point that has some nuance. Where do you dispose of morphine? Well, if we're in the hospital, we know where to dispose of morphine. There's been some companies, who've come out and they're selling activated charcoal bags. You can buy a bunch of these activated charcoal bags and drop them in. You can mix it with coffee grounds. You can check. We put a little bit of a reference on here. There's a protocol. The take-back programs are the official way. Find a take-back program. You can check with the pharmacy in your community. Mailbag sounds risky. But deactivation, home techniques, that's a whole industry now, where they're selling these activated charcoal bags where you can mix them with coffee grounds and stuff like that.